Thank you all for joining us. Welcome. We're excited to bring you today's webinar, The Future of Health is Local, Building Healthy Communities Through Local Economic Development Strategies. I am Leslie Lindo, the Director of Community Engagement for BALLE. And today I am pleased to be joined by Michelle Long, who will be moderating the session, along with Kimber Lanning, Yannick Redwood, and Tyler Norris, who will be discussing the link between community and economic development and population health. During this webinar, we invite you to submit questions in the Q&A box, which you should see at the bottom of your screen. And then Michelle will be incorporating your questions throughout the session. If you have any comments, notes, or need technical assistance, you can use the chat box and send a message to Jocelyn. For those of you who are new to BALLE, just to tell you a little bit about our work, we are busy cultivating the emergence of a healthy and equitable economy by connecting local economy leaders and funders across North America, sharing their innovative work broadly, and attracting investment to the local movement. So I'd like to introduce you to Michelle Long, who will be moderating the session. Michelle is the founding executive director of BALLE and represents the organization as a regular keynote speaker and author. She also serves as an advisor to the Schumacher Center for the New Economics, and in 2014 was named one of the Purpose Economy 100 for North America. Michelle is committed to growing the number of businesses and investors who are committed to maximizing well-being for all, and co-founded the Wellbeing and Business Lab in Oakland to align business and our economy in service to what makes us deeply well. Very much connected to our topic today. So we're excited to have you hosting this for us, Michelle. So please take it away.
Thank you, Leslie. It is a real pleasure to be on this call with some of my absolute favorite people and making this link between the strategies that work for our local economies, for equity and for health, and what actually makes people well in our local communities. So I'm very, very excited about this and so pleased that we're going to get to hear a little bit from each of these three people. Each of them will do a short presentation and then we'll have some discussion. Kimber Lanning, founder and executive director of Local First Arizona and BALLE board member. She's also a BALLE Local Economy Fellow. And I know that many of the people that are here in this call are familiar with her work and follow her work. She's a regular Citizen of the Year at the International Economic Development Council. She's a true entrepreneur and economic development specialist of the future. And we have Yannick Redwood, who is a new BALLE Local Economy Fellow, and I'm thrilled to be getting to know Yannick and her work and her brilliance. She is the CEO of the Consumer Health Foundation, so it is fascinating to be able to bring in and learn about why a healthcare foundation understands the links and the changes that we need to make in our economy if we want people to be healthy and well. She's a PhD and has been leading her foundation through a strategic shift, emphasizing the relationship between health, economic justice, and racial equity. And then we have Tyler Norris, who I can't say enough good about. Tyler is a true entrepreneur as well. He has started so many organizations across North America, reports directly to the CEO at Kaiser Permanente, and is shaking it up, I'd say, in helping the Kaiser to really look at total community health, and a true collaborator with many organizations across the country. Amazing, amazing strategic mind. So we are blessed to have all three of them. And a little bit more background about why we're going to be even having this call. It was just 2 years ago that after BALLE has been around now for, at this point, 15 years and working with hundreds of thousands of community entrepreneurs and those that support them, whether that be the strategic connectors like some of those on the phone or those in government, foundations, investment, to look at what is going to make more healthy, equitable local economies, we started to see that there really were patterns. There are patterns that work consistently, no matter the kind of community, that we need to see present in every place if we want health, if we want more equality in our society. And so we collectively with our community documented these. We called it a local economy framework. And then it was about maybe a year ago that we recognized that out of MIT, the Presidency Institute and Otto Scharmer's work, that they were finding what they called the acupuncture points for the transformation of capitalism. And developed completely separately, we recognized these are the same strategies. So we actually met to determine were there any differences really of substance, and there were not. Yet theirs were developed much more from a global perspective, an academic, maybe top-down perspective, whereas ours were very grassroots and bottoms up. And then we were with Tyler at Kaiser Permanente, which is, it would be the seventh largest company in the United States if it's private. It's actually a huge healthcare network. And talking to Tyler, recognized that the World Health Organization's social determinants of health, what actually makes people and societies healthy, were the same things that we identified in these local economy strategies. So do you have that field guide there, Jocelyn? Could you pull that up? With MIT and with Kaiser and with BALLE, just recently we released this field guide called The Future of Health is Local. And in it, if you want to turn the page, Jocelyn, you can see that we've just connected those social determinants of health with the strategies that are proven to create healthy, equitable local economies. And turn it one more time. Well, I'm sorry, one more time. I didn't realize it was a double fold like that. These 8 strategies, so you only see 4 at a time, but we'll send this, and it was attached with the webinar too. All of these 8 strategies are the same things that are making people building community wealth and building community health. And talking to Tyler much more about this, today, $1 in $5 in our GDP in the United States is spent on healthcare or sick care, 1 in 5, which is frankly incomprehensible to me. And by 2040, if we continue at this rate, we would be spending $1 in $3 on healthcare. And because of some significant new changes, including with the Affordable Care Act and some other things that we're going to get to in this conversation, the healthcare sector has become tremendous allies to all of us. Their goals are exactly the same. They have got to move from a business model that's been based more on how many heads are in beds, as they say, to actually they have to figure out how to make people well wherever they spend those resources. And so this guide that we did with Kaiser looked at all of the dollars that they can spend, all of the resources that pass through their hands. And apparently only 20% of what makes human beings well comes from clinical care. So what they can do through surgery or through medicine. 80% comes from the kinds of things that our community has worked on for years. Access to healthy food, walkable streets, communities where you can express your full potential, where you can be entrepreneurial, where you can start your own businesses. And so Kaiser has been looking at how they can build total community health, how they can use their procurement dollars and who they're purchasing from, how they can change how they hire, how they can use their investment dollars, how they build their facilities in ways that build the economic health of their communities as well as the total health of their communities. So we're going to get into all of this, but first I'm going to turn it over now to Kimber. She's going to kick us off to talk about these local economy strategies. What does make a community wealthy and equitable? So Kimber, let me pass it to you.
Great, thank you, Michelle. So I am going to talk and really sort of level the playing field and start us off with a common language so that we can better understand how anchor institutions spending directly impacts the health and well-being of the community in which they are anchored. And then I'm going to talk a little bit about sort of the aha moment that got some of those in the healthcare sector in our community thinking differently about their role within the context of a healthy local community. So what you're looking at on the screen here is an economic study that was done several years ago by my organization, looking at something as vanilla as the office supply contract that the state of Arizona had at the time with OfficeMax. And so what we set out to do with this study was to really show that, you know, you've got a $5 million contract here. How you spend it directly impacts the community in which you live. So here in Arizona, we spent $5 million with OfficeMax. And so in our study, we hypothetically applied that $5 million contract to 2 other companies. One of them was Whist, which is a 3rd-generation Arizona company based right here in Tempe, Arizona. And the 3rd one, which you're going to see in a minute, was Staples. I think we're all familiar with OfficeMax and Staples. Here in Arizona, OfficeMax had a regional distribution center here, but Staples actually does not. So the pie chart you're looking at represents how much money of that $5 million contract stays and recirculates in Arizona's economy. So with WIST, you spend $5 million and 33% of it stays here in Arizona and recirculates, but you spend the same $5 million with OfficeMax and only 11% stays. So Jocelyn, if you could advance, I'm going to explain the methodology that we used. The first thing that we looked at, which almost never comes into consideration when awarding contracts, is whether or not those companies provide health care benefits for their employees. What we learned is that WIST, the Arizona company, has 100% full-time employees with health care benefits, and that OfficeMax, the recipient of the contract, actually has 65% of their employees are part-time with no health care benefits. Now, those employees end up on the state's health care program. So that means that the taxpayers are actually writing the checks to cover the bills for the health care for OfficeMax employees. So in the business world, we like to say that OfficeMax doesn't actually have cheaper pricing. They actually are offering deferred billing because we're paying for that in a completely different way. So the second thing we wanted to look at was charitable contributions. WIST, the Arizona company, gives $35,000 a year to Arizona charities and has done so every year for the last 10 years and could prove it, whereas Staples nor OfficeMax actually could show that they've given anything in Arizona over time, the entire time that they've been here. And then finally, what we call second-tier jobs, and this is another factor that most people forget about, but how the economy works. You spend your money, $5 million in this case, with a company, and that company in turn does business. They have the cost of doing business. So what we found is that WIST, the Arizona company, they hired local accountants and graphic designers and website developers, payroll service providers, attorneys, and on and on and on. And you may recognize that as, we call that the multiplier effect. We spent the money one time, but it rippled throughout the economy. In addition to those secondary jobs, there's also the third time the dollar circulates through the economy when, for example, the janitorial supply company keeps the offices of the accounting firm clean, and the accounting firm is only there because Arizona companies hire them. What we learned in our study is that Staples nor OfficeMax support any Arizona jobs at all. All of those jobs are outsourced, secondary and tertiary jobs, to their home state. So Jocelyn, if you could advance. So what we were able to prove to the state of Arizona is that by going for the quote unquote cheapest price, they were actually losing $500,000 a year in economic leakage on that $5 million contract. We actually were able to show that with awarding the $5 million to Staples, they would pack and process Arizona's orders in Los Angeles and ship them here via FedEx. Not one Arizona job created. Now, I think we can all agree that that's not a smart way for the government to spend money, is to create the fewest number of jobs and to export that wealth far away. So what I'd like to do is get us thinking about, in addition to government, is what is the key role for anchor institutions to play, rather than viewing each of their budgets as an isolated bottom line. What I'd like to get us doing is thinking about how can we collectively think about our spend and the money we're spending every day as an effective tool and resource to help grow a more resilient local economy. And again, I think we're all fully aware that we live in a globalized society. What we envision is a series of interconnected, localized economies that are each thinking more broadly about what it means to build healthy and resilient local communities. And Jocelyn, my next slide just simply highlights, here in our community, I was having a conversation with one of our healthcare organization, foundation actually out here, and they suddenly had a light bulb go off when they were working with this gentleman who had been poor most of his life, had been working 2 to 3 jobs most of his life, and he was being pumped full of medicine to try to deal with his high blood pressure that he had developed as a result of his living conditions. And they said, what's it going to take to get this blood pressure under control? And he simply said, you want me to control my blood pressure? Find me a place that I can afford to live with meaningful work, where I can walk to work and get home in time for my kids and my grandkids, where there's a nearby green space for us to to have a nice time outdoors with our families. And the light bulb suddenly went off to her that, wait a minute, why are we spending so much time and resource on the pharmaceuticals to help bring healthcare under control, rather than thinking more broadly about what we can do as an anchor institution to enable everyone in our community to have access to healthy lifestyle options. So with that, I'm going to hand it back to you.
If you have any questions, please feel free to type them in the chat. We'll answer those after we hear from Unique. Unique?
Thank you. I just wanted to first thank BALLE for hosting this webinar. I think it's important for us to share our stories so that we can continue to visualize and actualize the kind of health promoting economy that our country so desperately needs. So I'm Unique Redwood, President and CEO of the Consumer Health Foundation. We are a private foundation in Washington, D.C., but we fund throughout the D.C. region. That is the District of Columbia, Northern Virginia, and parts of Maryland. There are 2 counties in suburban Maryland. And our funding areas are primarily health reform and economic justice. And I just want to say a little bit about the economic justice piece, because we get this question so much. Why is a health foundation focused on economic justice? And it's not curious for us. It's not interesting if people don't have the income, the assets, the ability to live in the right neighborhoods because of resources, then they can't be healthy. It's as simple as that. And most of our work, if not all of it, has a thread running through it of racial equity. And community wealth building is fairly new for us, but we consider that to be an extension of our economic justice work. Next slide, please, Jocelyn. So I just want to talk a little bit about an initiative that we participated in with several other funders. We've been doing this work since 2011, and it's called the Community Wealth Building Initiative. And unfortunately, it has stalled right now, but I think that there's some very important lessons that we learned that we can share with you. The initiative was built on the Evergreen Cooperative model in Cleveland, and it was housed at a local CDFI. And I just want to talk a little bit about the engagement that we did with hospitals. As was mentioned earlier, we're in a really interesting time in healthcare where hospitals, as a result of the Affordable Care Act, are being encouraged, let's say encouraged, to think more about how they can help people be well versus just treating people when they show up to their doors when they're already sick. And this is a very different way of viewing healthcare for hospitals. So I think it's really important for all of us to understand that this is a huge shift for hospitals and healthcare systems to begin thinking this way. And what we found in our work with hospitals were a few barriers that they named. One was that they're having to think now about different business models, right? So they were getting paid to treat people when they were sick. And if they came in with the same illness every week, they would get paid to treat that person for that same illness. Now that's not going to be the case, that they have to prevent that person from coming back to their hospital if they've treated them. And so there's a very different business model that they have to employ. And so at this point, when they're having to think about these new ways of doing business, it's really difficult. They have named the difficulty of thinking about partnering with local businesses for procurement, partially because of issues related to scale. So that's the other issue I wanted to talk about, is that these hospitals, they are procuring from very large intermediaries. And so to think about procuring from small businesses in their communities, they have named as a challenge. And I'm really just naming these challenges because you will hear them when you start working with hospitals or if you've already worked with them. And so want to put them on the table for us to talk about. The third thing here in the DC region, which I think is really important, is that different from what's happening in Cleveland, There were, in Cleveland, a neighborhood that was very, had high rates of poverty. The hospitals were right there. And for us in our region, poverty is very decentralized. There are pockets of it, but they're all over the region. And so people being disconnected, hospitals maybe being disconnected from the poverty that's very real, was a challenge here. And finally, I would say that one challenge was that hospitals locally may want to engage in this kind of community wealth building work, but there's so much consolidation happening where hospitals are being managed by a system that may not be local. And so trying to help hospitals make the case to their parent organization about how they can develop these strategies. So just wanted to name some of those barriers named by hospitals. And next slide, please. So the good news, there is some good news. I think there are several opportunities. I wanted to bring up a few of the non-clinical assets named in the report, The Future of Health is Local, that hospitals and health systems can employ to do exactly what we're talking about today. Their employment, procurement, and investment and innovation, which I'm calling impact investing. And I just want to talk about Holy Cross Hospital just as an example. I just had a conversation with them. We'll be bringing them to talk to our board soon. And they have decided to get to the $15 wage that we are, really pushing for from a public policy perspective, but they've decided to do that on their own at their hospital they've already started. And so the other thing that they've done is there are certain job categories that were contracted out, their janitorial staff, their cafeteria staff, and they've brought those back in-house because what they were realizing is that part of why it was cheaper to contract them out is because they weren't getting good wages and benefits when they were contracted out. So they brought them back in-house to ensure that they would have fair wages and benefits. And one of those benefits, which I think is really important for this category of worker, is a retirement contribution. They do both direct and matching contributions for their part-time workers. I believe it's 20 hours a week or more. And I just kept asking, how do you do this? How does a hospital do this? And one of the ways in which they do it is to manage those executive pay at the top, right? So that everybody in their system can at least enjoy a minimum wage of $15 an hour. So, so a really good example of what a hospital can do with its non-clinical assets, employment being one of them. The last two, I'd like to switch to the next slide, please, would be around procurement and impact investing. So I talked a little bit about the procurement challenges and scale, and so we'll get back to that, I'm sure, in the Q&A, but I want to zero in on impact investing now. Just like foundations, we have an endowment. Hospitals and health systems also have endowments. And I don't think that they have been tapped to really invest locally using low interest or no interest loans to support the kinds of social determinants of health that they're starting to think about. So the ones listed on the screen: affordable housing, childcare and early childhood development, economic security and education. These are the social determinants, some of them that hospitals are beginning to think about and beginning to think about how this can contribute to health. And so just a quick story, one of our board members, Sylvia Salazar, she lives in a building in DC, in a neighborhood that's rapidly gentrifying, I might say already gentrified. And the building was purposely being run down so that it could be sold for high profits. And she organized the residents of this building to buy the building using a loan from a CDFI. I think that loan could have easily come from a hospital, could have easily gone to the CDFI or been a direct investment. The second thing is that they're now working on a child care cooperative inside of that building. This is ripe for hospitals who are thinking about early childhood development as a social determinant of health. And we know, for example, that early childhood development, many studies have proven better health outcomes, better overall outcomes later in life. And it would support the development of local businesses, local childcare centers. So I think there are many opportunities here as hospitals are beginning to think about how they focus upstream to tap into the way they employ, the way they procure, and the way they invest their endowment dollars to improve population health. And I just look forward to further conversation about this with all of you and my colleagues.
Thank you, Unique. That was terrific. Such good, clear examples. And to build on Unique's point about the impact investing, if any other health foundations are listening, we're currently signing up our next cohort of the Community Foundation Circle, launching this fall, which is all about how health foundations and community foundations can do place-based mission investing. So you can contact BALLE for more information about that if that's an interest for you and you're on the phone. Next, I'd like to turn it over to Tyler.
Michelle, thank you for a beautiful framing of the opportunity at the intersection of health and healthcare and building strong, resilient, equitable local economies. And Unique and Kimber, just beautiful, beautiful examples. I think what I want to sort of start with is just to, again, frame the clear opportunity that Michelle addressed and as did Unique, that with the Affordable Care Act, increasingly health systems that have been paid for volume of treatment will begin to go at risk for improving health. And that means that in the marketplace for health, people who produce health, in other words, who grow healthy, affordable, fresh, local food, who create safe, affordable housing that has support services around it, that provides services for mobility and equitable access to work, to school, to get around the community, to home care, to all of those things that we know are determinants of health. Health systems will start to see you more clearly as producers of health. And given that organizations like ours are at risk, literally as an insurance organization for health, we're going to increasingly be looking at how do we purchase what you produce as health. And that really changes us from the grant-making conversation squarely into what Unique was getting at around new economic relationships. And we're not there yet, but this is what's coming and why this is so important. Because what we know is that the social determinants of health are the same as the social determinants of a strong, equitable local economy, of what creates education and learning, and certainly social justice and equity. That income, education, housing, transportation, food, safety, that's upstream what creates health. Most of that has nothing to do with the medical care delivery system, and yet if we're at risk for it, therefore we need to go. So I think that's the first piece is body, mind, spirit, healthy people. If I could go to the next slide, Jocelyn. This is just more to be provocative than anything else, a reminder that place matters. And this slide, 8 miles difference indicates a 24-year difference in lifespan. The last century, actually it was right around that, the last century, Americans increased their lifespan almost 24, 25 years. And now we're saying that the current generation being born may live 5 years less than their parents. And it's because we're not investing in what creates health in the first place. And the health sector, $3 trillion of the local economy is starting to get wise to what do we need to be able to do to address it. The next slide, I think, recognizes for us, but also for increasingly other health organizations, that we've been doing good things for a long time, making grants, community partnerships, doing good work in schools and in neighborhoods. But we're only now recognizing that those activities by themselves have not been producing a population level improvement in health. This goes right to the heart of what Unique was articulating so beautifully. That if we're actually committed So on the right-hand side, being accountable for our impacts, that we need to start thinking of ourselves as anchor institutions who not only make grants and do partnerships, but what do we need to be doing to measurably improve health status such that we not only have healthier people and create a strong local economy and education and all that, but ultimately how do we reduce demand on the medical care delivery system in order to be able to lower the cost structure that's soaking up about 20% of the economy, and in effect shrink the amount of money that we ultimately spend on healthcare and increase the amount of money we spend on housing and transportation and healthy food and all those things that produce health and jobs in the first place. So this is a really important move for the health sector from contribution to accountability, where partnership with local economic actors and those focused on social justice and equity are essentially vital for us. Moving forward, let's just go ahead and just very quickly, 10%, Michelle hit this beautifully, 10% is medical care, 30% is our biological inheritance, but what we're learning with epigenetics is that's being impacted right now. And so issues around race and inclusion and stress, that's impacting our genetic inheritance every day. But that big 60% of the socioeconomic environment and places that we make our choices, that's really the 60% we're talking about. I just want to make a couple points about being an anchor institution, and then I know we're going to open the floor to dialogue. So next slide, Jocelyn. Inside Kaiser Permanente, which is a large integrated delivery system that we provide coverage through a health plan and care, we are essentially at risk for the health of the members that we serve in the communities, and yet healthcare is only 10%. We need to look carefully at how we are showing up. So for example, Unique articulated beautifully, if we go kind of to that 11 o'clock position on the slide of that flower diagram, procurement. We do about $2 billion a year worth of community benefit, charity care and coverage, grant making. We buy $16 billion a year, 8 times as much worth of stuff. So again, I don't need to repeat what Unique did. The extent to which we can localize our procurement and drive it with the multipliers that Kimber described is a direct way in which often the largest employers and among the largest procurers in your community can be driving that virtuous cycle that Kimber said. How we purchase matters. So when we hire D&B Painting here in Oakland to paint our new medical office building, we not only create a bunch of living wage jobs right here in Oakland, but we don't export that, not only those jobs, but the wealth that's created from those, we don't export that out of the community. It actually stays and circulates inside, and yet there is no more greater predictor of health status than income. So we can be doing that every day. Environmental stewardship, I'll just kind of go counterclockwise. We now meet half of our energy targets for our facilities. We have 700 some facilities, clinics and hospitals. We now are meeting half of our energy requirements from wind and solar. When we made a big 20-year wind and solar purchase in California, we created hundreds of green jobs in the Riverside area through the solar arrays, and up in Alameda County through the wind generation. That is so reducing our carbon footprint, reducing the amount of carbon that's driving asthma and certain cancers, and creating green jobs in our footprint. A great example of a triple win. When we build our facilities in a way that aren't just sort of bastions of fortresses, if you will, but more blur into the neighborhood, we create places where people meet with each other, where shops can create, where there's a lot of economic activity. And so in other words, if we go around the horn from how we engage with our government relations to help support policies around transportation, around food, around living wage jobs, and we lean in as about what we can do as large employers and influencers. And then to the point of Treasury, to again build on Unique's point here, let's think about, and then I'll sort of transition with this into questions. Let's say that, first of all, we know that diabetes, hypertension, heart disease are among the great drivers of chronic disease that's driving 80% of the $3 trillion. And we know that access to healthy, affordable, fresh foods and nutrition, particularly for lower income members, are one of the most important ways that we do that. So we can deliver world-class care, but if we send a person back to a food desert where they live without access to that food, sort of shame on us at one level. And every healthcare organization knows that. So we say, what can we do to help scale access to healthy, affordable, locally grown food, et cetera? Well, we can do what we've traditionally done, which is we make grants. Good for us. We ought to keep doing that. In fact, we need to be doing more of that. But we can be using our food purchasing. We buy $150 million a year worth of food. So we can increasingly buy that local and regional, and we can partner with our friends at Dignity Health and Sutter Health here in Northern California, or St. Joseph Providence down in Southern California and in Washington and Oregon, and the school districts, and we can start to use multi-year contracting to contract into local food producers, driving all the economic drivers that Kimber was talking about earlier. And in fact, those contracts become bankable so that if the local business wants to buy a truck or a refrigerator or flash food pasteurizer or something that they need, they can use that contract. And then thirdly, to Unique's point, with our treasury, we can use grants, we can use contracts. We could also make our capital increasingly available to help those companies be able to borrow access to capital or do loan guarantees. We're doing that with a community development corporation right now in the East Bay, and heated real estate market where a multi-unit building goes onto the market very quickly, and the people who want to create market rate housing snap it up and turn it into market rate housing immediately. We're trying to preserve affordable housing and reduce displacement in our communities. We're trying to make our capital available to help those community development finance institutions and community development corporations be able to access and buy those buildings right now to make them available towards affordable housing and lock in the kinds of strategies that reduce gentrification and reduce displacement. So these are ways that healthcare organizations are increasingly, often as among the largest economic actors, can become full partners with you in local community economic development, because we are increasingly seeing you as the producers of health that we need to purchase from.
Absolutely beautiful, Tyler. I love that. I love that. I love how the incentives are aligning. What is it, just to be clear, what is this massive sea change that we're under? What has just happened? Is it true that because of the Affordable Care Act, healthcare systems can no longer exclude people from their systems when they become unhealthy, and so the healthcare sector may become bankrupt if we don't figure out how to make people well? Is that what's happened? Is that what the recent change is?
Well, just really briefly, and then Unique may want to add to that, and of course there's a lot more. The Affordable Care Act, or sometimes talked about as Obamacare, has a lot of dimensions to it, and it's very complex. Most important thing is you can't, people with pre-existing conditions can get insurance, and then there was the expansion of Medicaid in most states so that more people with slightly more income can access health care, and then the development of the exchanges, which allow people to have more transparency in buying health care. That's the big piece. But what we're describing here is that with the Center for Medicare and Medicaid Services and the innovation, CMMI as it's called, their innovation piece, we are increasingly seeing health systems not being paid by Medicare and Medicaid for treatment, but rather going at risk. So for example, Hennepin Health, that takes care of 10,000 homeless and housing insecure population, they're taking a block amount of money from Medicaid. And one of the first things they did is that they got people apartments and stabilized them. In other words, they went at risk for those 10,000 people for whom they provide care. And they said the most important thing we could do is stabilize them in housing. So again, in that example, there's a recognition of a shifting of incentives, 180 degrees opposite, from beds full to beds empty. And it's not widespread yet, it's just getting going. We'll see much more of that in the years that come, but it starts to shift that incentive to healthcare needing to do the things that create health in the first place, rather than just treatment, and therefore housing and food and living wage jobs and all that become part of the answer.
Wonderful. Unique, was there something you wanted to add?
Yeah, just really quickly. I mean, I think one example of what Tyler just mentioned is, for example, the readmission rate to a hospital, right? So you come in, you're sick, you've had a heart problem, and if you keep coming in for that same problem over and over again, the new way that we're headed, you won't get reimbursed in the same way, right? Before, you used to get reimbursed every single time that person came in with a heart problem. And so it's those kinds of indicators that are being monitored, right, for hospitals to be able to be reimbursed the way that they need to be. And if they don't, there is some population level things where if you get reimbursed and you can't use the money to take care of that population because you keep treating people as they're sick, it incentivizes that hospital to say, wait a second, what else can we do so that we can protect those dollars that we're getting reimbursed for, and prevent people from getting sick in the first place. So the incentives, just like Tyler said, are absolutely shifting.
It's a wonderful time to come together. And people like Kimber here who are on the phone, her work, she is and has for 15 years been working in a very scrappy way to build real health, to build equitable, healthy economies. Wildly under-resourced. As we know, there's some $80 billion a year that's spent on economic development incentives at the state and local level, primarily for large corporations and not for any kind of the work that Kimber's working on. So how could a Kimber partner with you at the local level? Those are the people that are on the phone. What do they do with their local healthcare system? There's some 5,000 hospitals and local healthcare systems. Talk some about the community benefit agreements that they have to go through, and how would she partner with you?
Michelle, I want to be clear. Were you asking that of, for example, health systems, or were you going to the audience there?
No. I was asking you primarily, Tyler or Unique. How would anyone like a Kimber, who there's many people on the phone who do community and economic development work, how do they bring together a larger view of total health tied to economic development in their communities? What resources are now available, and how do they go about accessing them to build the kind of health that we want in our communities, to do the work they're doing?
Well, one of the things, and this may tie to Unique's point, is that there are some challenges for large health systems. There are some apparent efficiencies in buying in large scale, which Kimber sort of laid out from the beginning. But there are a number of areas that we've found that are easier to begin with. One of them is around food. And so when we start to think about what we're serving in patient rooms, in cafeterias, on the food carts, through farmers markets, of which we have 55 right now associated with our facilities, and also around catering, there's all kinds of things that we could be increasingly doing with local purchasing. So we could work with partners like Kimber to identify what are the local companies that match our values, that can create the kind of healthy, we have something called Healthy Picks, which is our standards for healthy food. What kind of vendors could increasingly be able to do that? We tend to preference women and minority-owned firms, often in our catering and other kinds of contracts around that. So we could begin to focus on that. Laundry is another key area. Painting, printing. There are a number of key elements like that are places to begin. And so what we've found is just sort of the beginning of strategies. In Los Angeles right now, we're partnering with a number of other health systems, frankly, our competitors, to do a forum where a number of women and minority-owned businesses, 100 of them, are going to come together to prepare them to compete to win contracts with organizations like ourselves. Kimber's organizations can be doing that kind of a thing too. So healthcare organizations working with Local First, Arizona First kinds of partnerships can actually find the sweet spot between what is the community producing that wants to be bought, and how would those local companies kind of get in on contracting opportunities, and then help the healthcare organizations start to find the lower hanging fruit and the kind of things that we could do to start to begin to localize. And then it becomes easier later to start looking at more complex purchases, or to push our vendors to increase the subcontracting to local purchasers as well, which is another really important secondary impact. I don't know, Kimber or Yannick, what you would say to add to that.
So just really quickly, so Tyler described kind of, one system. I think that it's good to start with a system that already believes, right, and already has begun this work. So that's the one thing that I would say is that, find your partner who is already on the way, right? Like the Holy Cross Hospital, already trying to do the kinds of things that we hope they would do. Because I think part of this is about leadership, right? And being able to bring together hospitals and health systems who want to demonstrate this kind of leadership. I do think that coalitions of funders, local government, these health systems make sense. I think it creates more of accountability movement together when you bring people together, maybe versus the kind of one-on-one work that we tried. So I think that's one thing to add. I would also add that we're trying something different now with our hospital associations. So just invited the president of the Maryland Hospital Association to come and speak to our board about their equity work. I think because their footprint covers many hospitals, that might be another way. So if I were in Kimber's shoes, I would do some kind of coalition building if there is time to do that. So coalition building with people across sectors, hospital associations, and then really identifying those hospitals or systems that have already begun to create the kind of leadership that I think this kind of work needs.
And then, Michelle, if I could just add to that, I just wanted to share one of the strategies we took on a couple of years ago, trying to figure out how do we take, we have a coalition now of over 3,000 businesses, and how do we effectively help these anchor institutions localize in any capacity. And we figure that some is better than none. So we did we created a partnership with a mid-sized anchor institution called Copperpoint Mutual. They have about 518 employees out here. And we got them essentially from 45% of their spending, which was local, up to 82%. By working hand in hand with their procurement department, we learned what they needed, and then we went out into the community and found those companies and helped negotiate those contracts. Now, that's really labor intensive for an organization like mine. However, the outcomes were remarkable. We hired an economic study group to come in and measure what does that mean that they source 82% now locally. And there were two key findings. One of them was they spent $100 million, but it had a $500 million positive impact on Arizona's economy by the time those dollars stayed and recirculated throughout the community. And secondly, while they, as I mentioned, employed directly 518 people, we proved that they were indirectly supporting 3,600 Arizona jobs because of the way they were sourcing. And by the way, for those anchor institutions on the phone, we saved them 1% on their budget. So we are not asking them to spend any more. And then there's also an additional impact. They reduce their carbon footprint in a lot of cases as well. So we're in the process right now of course, we got some good media coverage on that, and we're helping other anchor institutions begin to look differently at this. But right now I'm doing the research to find out, what do other anchor institutions buy? You know, send me your list of the top 20 things you spent money on last year, and let me see if I can help you even move one of them. Anything we can do to be helpful. And so we're building some great partnerships. As Yannick mentioned, it really is about creating those relationships in the community.
Wonderful. And we have other people in our community, local economy fellows in Albuquerque and Newark, who've been hosting summits locally of healthcare system, business, government, foundations, investment, to look at this specific, how do we build the coalition for this kind of change in our community? How do we make the relationships? And Leslie can send in follow-up the upcoming one that Eric Riego is hosting in Albuquerque, so you can see sort of his agenda and how he's thinking about that. And I wonder if, what advice would, either you, Tyler, or Yannick, or maybe even Kimber, you'd be able to give some advice here on this one. related to who do they approach in their healthcare system? Who in their hospitals or locally? Who are they? Who are the people on this call that are doing the kind of work to build entrepreneurs and farmers and in all the populations and demographics of their place? Who do they approach about partnership and about setting up these kinds of summits and these kinds of coalitions?
Yeah, so this is unique. I think what will end up happening is you get referred to the part of the hospital that is about kind of community affairs, which is great. We need community affairs. We need that kind of relationship with hospitals and health systems. But what we have found, it's those decisions don't get made there. They get made with the people who, and not necessarily even with the president, but it's with the procurement department. If you're talking about procurement, there are these long-term contracts that many of these systems are already in. And so it's not as easy as just saying tomorrow, now we're going to shift to a local strategy. So working with those procurement officers, thinking about with those health systems about how those procurement officers are incentivized. I mean, there's a lot that is related to procurement. So I think you'll end up getting referred to the kind of community arm, but that's not where those decisions get made.
Tyler, would there be anything you could add about the kinds of internal challenges that the healthcare organizations might be facing? They're often the largest employer, or can be in many communities, the largest employer and purchaser in that community. What kinds of challenges? How can we help to make their lives easier?
Well, couple things. One is Unique is definitely right. Sometimes the community benefit or public affairs people are the first line because they're out in the communities more. It's a great place to begin. One of the things that we're doing, and we're actually convening a network of about 40 healthcare anchor institutions that are helping set the pace for that later this year. But what a lot of us are all trying to do is to help our procurement people, we call it buy to pay inside our part of our organization, or our supplier diversity folks, kind of think a little bit more about this and reach out to their equivalent of Local First, Arizona First. So we're actually trying to prepare our HR workforce, our people who can help build the local workforce, our impact investing groups, our procurement group, our technology group, our government relations, to be more available to actually work with community partners around this, so that the community benefit is not the only piece. In terms of incentives, it's challenging, and this is the work we really need to be doing. You know, when we're trying to make healthcare more affordable, so the first thing a procurement person does is, how do we get the best deal for a product? And you start to see something that's 1, 2, 3, 4% more. You go, well, that's only going to raise our costs to pay higher. So one of the things we need to start doing is, how do we shift the incentives of our procurement people to see the larger value proposition that Kimber laid out at the outset of this call, so that we can recognize that 1 or 2% apparent savings is not a savings whatsoever as it relates to the broader, when you bring in the externalities that Kimber described so fully. So that's work we need to do internally. The same thing is true with our impact investing group. We invest to actually protect those non-operating revenues so that we can keep healthcare costs down. But how could we increasingly use those impact investing dollars to invest in the local economy more? Those are different mindsets and different muscles than we've increasingly had. And you'll be finding your healthcare organization trying to figure out how to do that better. But we may need to help bring each other along for a while, which is exactly what Kimber and Unique have been talking about.
Anything you'd add there, Kimber?
No, I just think that he's, as always, spot on. It really does take 1 or 2 people at an organization to begin to impact change. And as Unique mentioned, it's relationship building, and it's really, I think that the way I would characterize the challenge is that we are basically coming in with a viewpoint that is saying to a company whose entire procurement division has always believed that cheaper is better, right, and trying to change the way they think and maybe not getting them to spend any more money, but even if they do spend more money, helping them recognize how it's a savings in the long run. There's a cute little story I tell to get people thinking. I had a great little healthy salad on the counter at my work, and this kid came up and said, "Oh, that looks good. It must have cost you a fortune." And I said, "No, no, no, I'm saving a fortune." And he said, "What? You know, huh?" And I said, "Well, it cost me $8, but think of all the money that I'm saving in the long run by not eating $2 hamburgers in terms of my health care down the road." And of course, he just kind of scrunched up his face and thought that was a strange thing to say. But essentially, that's what it's very basic. It's just that people are not thinking about it necessarily that way right now. And so there's a lot of meaningful conversation that needs to happen before you can really motivate people to do this work.
But that is the beautiful thing right now, is that the incentives are aligning. So it's not out of any, it's out of enlightened self-interest that we have the possibility to make these shifts. There's a question here, Tyler, related to Schedule H and community benefits agreements and what has to happen in each community. Can you share more?
The first thing that is most obvious around Affordable Care Act and the requirements of non-profit hospitals is to do community health needs assessments every 3 years. And so this is a year where most hospitals are actually doing that. It's one thing to get the data. It's another thing altogether to do meaning making with community partners about what does this data mean. So we see food insecurity, we see economic insecurity, we see unsafe places to walk or be active or get to shopping or sort of be outdoors. So what does that actually mean and what are the opportunities? But the second half of that is the implementation strategy. And so, and each hospital needs to submit that back to the IRS. So there's opportunity for community partners to work alongside their healthcare organization, in fact, encourage competing health systems to work with each other to identify implementation strategies that are along the lines of what we've been talking about. And so developing a workforce pipeline, procuring more local, doing impact investing, supporting affordable housing, food, things that we've been talking about, can very much be part of how a hospital does its implementation strategy and what it reports back to the IRS. So this is all another opportunity to sort of use the hospital reporting requirement to actually drive a localism strategy. Unique, I don't know what you'd add to this. You've been right in the thick of it too.
Yeah, even before, so Tyler mentioned kind of the ways that the assessment can be used for some of these social determinants of health, but in many places, that assessment is still being used to just kind of track, the rate of heart disease or the rate of diabetes. I mean, a very clinical, individual disease orientation, and we do need that data. But what the opportunity is to move upstream, right? To think about if heart disease is showing up in a community assessment, could we also assess for access to food, healthy food? Could we also assess for what are the parks like? What are the sidewalks like for walking? What are the employment opportunities like? And so there's this opportunity to blend this requirement, this Community Health Needs Assessment requirement, with a social determinants strategy, and then do the kind of implementation that Tyler mentioned. So I think the opportunity is really around how we push the CHNA to be a much more upstream analysis.
Wonderful. I'm so sorry we're coming to the end of this call. I absolutely, there's some wonderful additional questions that have just come in related to how we can share some of the healthcare industry's experiences and knowledge gained with other anchor institutions to multiply the effect of growing our local economies. Some of that's happening with the Community Foundation Circle, as well as in healthcare and in government. There's much more to say. This conversation is just getting started. The resources will continue. I know Leslie wants to make a couple closing comments to send us off, but I want to say thank you to the three of you. Really, each of your expertise is incredible, and I'm so glad to be in this journey with you.
Excellent. Yes, thank you all so much. Very insightful and a lot of really great questions that were going on throughout this session. So I just wanted to thank everybody again for joining us today. We really appreciated the enthusiasm of the exchange, and just wanted to make sure y'all knew that we will be sending you a link to the video and the recording of this webinar, and that you can also find more resources, including the online version of our field guide, on our website at bealocalist.org. And then, as Michelle brought up, we will be continuing this conversation at a conference that we're co-hosting with the Robert Wood Johnson Center for Health Policy in Albuquerque, New Mexico, and that will be October 7th of this year. And you can see this event on our website on the events page. So we hope we'll see you there, and so that we can continue this conversation. Thank you all again for participating today.
Thanks everyone very much.
Thank you. Bye-bye.